write as. So these words, if you remember, they will help you in exams. Okay. So it causes mydriasis, it causes blindness, it causes redness, it can cause tachycardia at various doses. It has so many effects. So briefly we will brush up with the last class classification and we will move over to the further other drugs of this classification. So we started with the autonomic nervous system, how it is there. It is not controlled by the will of the person. In that we have this central and peripheral nervous system. So you saw that we have this both somatic, visceral, sensory organs, and in motor divisions we have this parasympathetic and sympathetic divisions. So you already know that how our sympathetic system works. They are the fight and flight hormones. Okay, so that means a system is there to counteract this fight and flight system, that is a parasympathetic system, which can give a relaxation mode for that. So these were the various organs where we had our sympathetic and parasympathetic action primarily. Of course they have other functions also. Primarily these are the functions which is carried out by sympathetic and parasympathetic system. And here we learned that the parasympatholitic action is somewhat similar to our sympathetic action with some exceptions. So parasympathomimic, where all these receptors are present, preganglionic and postganglionic, and also in the somatic system. So it is 75% of all the parasympathetic nerve which is present in the vagus. We already saw that where these receptors are present, the parasympathomimetic receptors. We have both nicotinic receptors and muscarinic receptors, and the anticholinergic drugs. We are concerned about the muscarinic antagonism, that is M1, M2 and M3 primarily. And the drugs which are blocking this receptors such as neuromuscular junction are called as skeletal muscle relaxants, and which block this autonomic ganglia, we call them as ganglion blockers, and they are rarely used therapeutically. So the therapeutic effectiveness lies within the anticholinergic drugs which are blocking this muscarinic actions. So here you saw what are the agonists and the antagonists. So M1 antagonists, we have this pyrazapine, telazapine, which are used to suppress the gastric acidity. Tropitramine, M2, we rarely use it. Tolterodine and diphenacin we use in urinary symptoms and the urinary stone formation, or due to pressure symptoms, or in prolapse conditions where the urinary hesitancy, urgency will be there. So this is our classification. Natural alkaloids, we have atropine. Mydriatics, we have homatropine and tropicamide. Of course we can use this atropine, but atropine when used locally, don't talk. Atropine when used locally, they can also cause that local action, that is 5 to 7 days mydriasis will be there, the person can become blind. That's why we are using the shorter acting alternatives which can be medically helpful or therapeutically helpful. Those are homatropine and tropicamide, which are commonly used for eye testing, and also in case of iridocyclitis where we need alternate mydriasis and meiosis. GI spasmolytics, we have oxyphenonium, anti-ulcer drugs, that is pyrazapine, M1 antagonist, antihistaminic action, ipratropium, anti-asthmatic, ipratropium and tiotropium bromide. These are bronchodilators. Urinary system, we use this flavoxylate in BPH, benign prostatic hypertrophy. We have oxybutynin, trospium, antiparkinsonian drugs where we are avoiding the excessive cholinergic action due to unopposed dopamine action, where we can use this benztropine, piperidine and trioxypheniramine. So primarily we were speaking about the action of atropine. So atropine you saw on various systems how they act. So this one diagram I have left this in the class. I will come to this today. So what is the action of atropine? Atropine on CNS, primarily when used orally they have lesser penetration, but at higher doses they have this stimulation effect which can cause restlessness, disorientation, hallucination. Then on CVS at low dose we have this bradycardia, And at moderate doses, we have this tachycardia, chronotropic and chronotropic action. At even higher doses, what can happen? They can block the release of nitric oxide and vasoconstriction effect is lost. So atropine action on the eye. What we learned about the cholinergic system? 3 C's: constrictor pupillary muscle, cholinergic nerves. They act on the circularly placed muscles and they bring about constriction of the pupil. Okay, so here you can see the constriction of the pupil can be by direct action of the cholinergic system or indirect action of the adrenergic system. Okay, indirect action of the adrenergic system is by anti-adrenergic effect. Direct adrenergic effect is mydriasis. Okay, indirect cholinergic action, that is mydriasis, can be brought by our atropine, which can cause cycloplegia of the circular muscles. Okay, atropine can cause cycloplegia of the circular muscles, and as it is not by directly acting on the radial muscles, by acting on the circularly placed muscles, we call it as indirect mydriasis. Okay, anti-adrenergic drugs can bring about indirect meiosis. Anticholinergic can bring about indirect mydriasis. Remember, this is the practical examination, and if you remember this, you can get through the practicals. So once mydriasis is there, you can go for photophobia, and these are the drugs which are contraindicated in glaucoma, where once mydriasis has taken place, there can be trabecular meshwork blockade, where aqueous humor transmission will be inhibited. So atropine action on the smooth muscles, we need to remember it is decreasing the GI motility. Okay, gland secretion can be decreased, as we call it as dry as bone. Okay, so atropine, you can remember where it at low doses they can act on the saliva, sweat, bronchial secretions, all are decreased. High mydriasis, bronchial smooth muscles, relaxation. Okay, bronchodilation is there, heart, tachycardia, gastric line, decrease in the secretion, all these effects are there. Okay. So today we should start with this scopolamine. Before that, I would like to show you one thing. Okay, so here, so these are the, we need to remember some drugs which can inhibit the acetylcholine release. Okay, there are 3 drugs. Can you remember them? The first drug is hemicolium. Okay, it blocks the incorporation of the choline into this acetylcholine formation. Okay, so that drug is hemicolium. Then vesicular incorporation is inhibited. The drug is Vesamicol, B4B, and one more drug is there which can prevent the release of this acetylcholine from the nerve endings, that is botulinum toxin. So our atropine is a drug which can compete with the acetylcholine for the receptor and bring about its action. Okay, so one more thing I want you to concentrate here. You can see here there is the acetylcholine autoreceptor. Can you see here? So you can see an arrow which is going from here till there. Okay, so what it does mean, when the acetylcholine is in normal levels or in excess, what can happen? This acetylcholine can go and act on this autoreceptors. Once it can go and act on this autoreceptors, what can happen to the acetylcholine release? It can be auto-regulated. Okay, so these autoreceptors can regulate the acetylcholine release. Okay, that means it is a negative feedback mechanism. Okay, so if the acetylcholine can go and act on these autoreceptors, what can happen? Acetylcholine can release can be decreased. Okay, so that's how it is maintaining its autoreception. Why I am telling this is because atropine at low doses in the CVS, we told that it can cause bradycardia. How this was possible? Okay, atropine action on the heart, we remember it as tachycardia, that is at the moderate dose. At low dose, what is happening? This atropine is going and blocking this commutative site. Okay, so once atropine can come and sit on this receptor, what can happen? The excessive acetylcholine from here, it cannot go and act on its autoreceptor. Okay, so once there is no action on its autoreceptor, the acetylcholine here regulation will be not there. So acetylcholine will be acting uninterruptedly on the heart. So acetylcholine action on the heart directly is to decrease the heart rate. Okay, so it is a vagomimetic acetylcholine which can decrease the heart rate at low doses. This is what is happening. But at higher doses, what is happening? It is acting on the M2 receptors, okay, which are present on the SAN and AVN. On M2 receptors, SAN and AVN action, it can bring about the chronotropic action and also tachycardia. So that's what I wanted to show you. And one more action. So at acetylcholine, here we are seeing the effect on the blood pressures. Okay, so atropine blocks the muscarinic effect of acetylcholine. That's what we know. Okay, here how it can bring about its action. So acetylcholine, what it can does? It can decrease the heart rate. Vagal action, acetylcholine is released. What it can does? It can decrease the heart rate. Normally this is happening. So here you are giving 2 microgram of acetylcholine. What is happening? There is sudden fall in blood pressure. Okay, once acetylcholine is metabolized, again there is recovery of the blood pressure. Here you can see after we are increasing the dose by around 100 times. Okay, so 50 micrograms. Okay, what is happening? Again the blood pressure is falling till the acetylcholine is metabolized, and again it can regain back its blood pressure. Okay, so this is at low dose and moderate dose. So but sometimes what can happen, when atropine is given, there can be increase in the heart rate. But one more action is atropine can block the action of the muscarinic receptors. Do you remember? Atropine can block the muscarinic action of this acetylcholine. So what about the nicotinic action on the ganglia? They can increase the heart rate. Okay, at the CNS, through action on the nicotinic receptors, the heart rate can be increased. So thereby the blood pressure is increased. Okay, so acetylcholine has action of directly by vagomimetic action. There is decrease in the heart rate or controlling the heart rate. It is based on the action on its muscarinic receptors, but its action on its nicotinic receptor at very higher doses, by action on the CNS, it can increase the heart rate. Okay, this is the graph which is given in your practicals. I just thought of putting it. So coming to the drug Scopolamine. Okay, how we need to just compare it with its action on the comparing to the atropine. Okay, so it has almost all the actions of atropine, but hyoscine has more CNS penetrability than the atropine. Okay, so more CNS penetrability means we can use it for some diseases. Here we can use this drug for the motion sickness. Okay, so we use it in the form of a transdermal patch. Okay, Scopolamine or hyoscine, it's a belladonna alkaloid, produce peripheral effects similar to atropine, but as it has greater action on the CNS and also a longer duration of action. Okay, it is most effective in CNS and it is effective in blocking the short-term memory. Okay, and produces sedation. It can cause amnesia, drowsiness, euphoria, relaxation and sleep. Okay, you can put together all of these properties. We can use it as a truth serum. Have you heard of this truth serum? Okay, the police interrogation, what they use a drug which can produce little bit of sleep, which can produce a euphoria, and the patient should be amnestic. He should be forgetting the short-term memory he is when caught by the police or something like that. Okay, he will be little bit dissociated from the common proceedings which are happening, and he can open his mouth. Okay, that means he can rely on some of the facts he may be uttering out. Okay, so that's why these drugs or the scopolamine is used as a truth serum. Okay, so it can be given by all the 3 routes. Okay, parenterally, orally, and also transdermal patch. Transdermal patch, slow release, we use it for motion sickness. So ipratropium bromide, it is a more commonly used respiratory anticholinergic drug. Okay, why we are calling it respiratory? Because it is more commonly used by inhalational route for COPD and chronic asthma. Okay, COPD means chronic obstructive pulmonary disease caused by excessive smoking or tobacco abuse. Here you can see it is the inhalation derivative of atropine, useful in treating asthma and COPD. It is also useful in rhinorrhea and is an excellent bronchodilator. We also have agents such as homotropine, cyclopentolate, propylcomide. We find their use in ophthalmology, okay, for mydriasis. Mydriasis we do it under 3 conditions. One is for surgery, one is for ophthalmic examination, okay, or fundoscopy, and another is for mydriatic and myotic. Alternatively, they are used to prevent the adhesions between the iris and the sclera. Okay, when there is a penetrating eye injury, what we call it as iridocyclitis. Okay, so in all these conditions, we can use these drugs. So centrally acting anticholinergics, we have already told this. It's just repetition. It is benztropine, triacylphenidine, and benzhexol. We are using it in Parkinsonism, where there is imbalance between the cholinergic system and the dopaminergic system, which is taking place. Okay, so we have used this antipsychotic drugs for a long time. The patient is developing the extrapyramidal symptoms, and sometimes these drugs are also used there. Okay, so extrapyramidal symptoms and also in treatment of this Parkinsonism. See, in Parkinsonism, we need to remember the primary effects, that is rigidity, akinesia, tremors. All these symptoms, they are controlled with the help of this anticholinergic drugs. And nowadays, they are also telling that, like along with use of this dopa agonists such as levodopa and carbidopa, we can start with this drug initially only. So initially, also they are tried, like along with the primary line of drugs. So coming to the next group of drugs, urinary antispasmodics, okay, flaxolate. It is used in dysuria, urgency, infancy, and pain with genitourinary infections. So that spasms, all these are relieved. Okay, oxybutynin, direct antispasmodic effect on the smooth muscles and anticholinergic effect. Decreases the frequency of voiding. This frequency of voiding will be increased in BPH, prolapse uterus, and in some cases of cystitis, okay, interstitial cystitis, what they call it as interstitial cystitis, prolapse uterus. What is happening due to the pressure of the uterus on the bladder? There is increased frequency. In BPH, what is happening? There is again problem of there is excess of urine, but the patient is unable to void because of the constriction through the urethra. Tolterodine is a competitive antimuscarinic anticholinergic that inhibits the contractions. Okay. So some words about the ganglion blockers. They are the least commonly used or rarely used drugs with very few exceptions. So they act on the nicotinic receptors of the autonomic ganglia. As they are non-selective, their action is not required for the therapeutic effect. So their effect is complex, unpredictable, because you saw the muscarinic action of the anticholinergic drugs was to bring the tachycardia, but the nicotinic action was increasing the blood pressure. Okay, so those things, for example, like acetylcholine, nicotinic action was to increase the blood pressure. So the action will be unpredictable when you use this ganglion blockers, and they are mainly used in experimental pharmacology. Okay, where we are trying these drugs on the animal or the isolated preparations. They increase the peristalsis and secretions. On large dose of nicotine, what can happen? Blood pressure falls because of the ganglionic blockade. Okay, we saw that acetylcholine, when muscarinic action is blocked, it was increasing the blood pressure. Here, on large doses of nicotine, because of excessive nicotinic action, there can be fall in the blood pressure. So, activity both in GIT and urinary bladder musculature will decrease at higher doses. So, trimethophan, again, it's a short-acting competitive nicotinic ganglion blocker and is given by IV route. Okay. When no other drug is available or the patient is in hypertensive crisis, maybe something like 200 by 100, something like that, so we can use these drugs, the ganglion blockers, where the central acetylcholine action can be prevented to decrease the blood pressure. Okay. And they are also using dissecting aortic aneurysm where other agents are not used. What do you mean by dissecting aortic aneurysm? Have you heard of this? Dissecting aortic aneurysm means where the aortic wall, there is intima, media and external. Okay, so what can happen? The blood can pass through this intima and make one more pathway through the media. Okay, that means there are two pathways within the aorta for the blood. That if it goes on dissecting the blood vessel, what can happen? There can be tear of the aorta. In such conditions, we can go for this drug in case of dissecting aortic aneurysm. So neuromuscular blocking agents, yes, they have their use, starting with do you remember some drugs? Pancuranium. Skeletal muscle relaxants is over for you? No. Okay. So there are some drugs we are using these then. Presently we have so many drugs as skeletal muscle relaxants. We have centrally acting such as the diazepam group, bromocriptine, and peripherally acting we have this non-depolarizing, depolarizing. Okay, so many things are there. Succinylcholine is commonly used for the local effect of bronchodilation or bronchoscopy, all these conditions. Okay, we have so many drugs. We will be learning it in the later class. Okay, we have a separate chapter for that. Drugs blocking the cholinergic transmission between the motor nerve endings and the nicotinic receptors. Okay, they are structural analogs of acetylcholine. So clinical uses, it is just a summation of what we have studied till now. Okay, you can start with eye. What are the effects? Where we can use? What are the three things I told? Mydriatics. Which drugs are commonly used as mydriatics? Homotropin, tropicamide, and C, cyclopentolate. Okay, homotropin, tropicamide, cyclopentolate. Where we are using it? Before surgeries, for fundoscopic examination, for ophthalmic examination, in treatment of iridocyclitis, where we are afraid of adhesions between the iris and the sclera. Okay. So in these conditions we can use this mydriatic and cycloplegic agents. So in respiratory system we are using it in asthma and COPD. We usually use it as a nebulizing solution along with a adrenergic drug, that is salbutamol. Okay, so we use ipratropium bromide, tiotropium bromide. Okay, either of them plus salbutamol, and also we can use the inhalational steroid. These are the most common three inhalational drugs used in asthma. One should be salbutamol salmeterol, that is a bronchodilator, beta adrenergic agonist. Another one is the anticholinergic drug which we are using to decrease the secretion. One more drug is a universal anti-inflammatory drug, that is steroid. Okay, beclomethasone or budesonide, all these things are steroids. So these are the three drugs which are used in various combinations to treat this bronchial asthma and COPD conditions. So serious, we know that at low doses it can cause bradycardia, at higher doses it can increase the heart rate. So GI antispasmodic action. Okay, dicyclomine. Have you heard of dicyclomine? Did we learn it in our classification? Don't remember? Here we have not given it. Okay. Remember, dicyclamine we can use it for antispasmodic action. So most commonly used injections and tablets, spasmodic, they are used for the GE conditions. Okay, gastroenteritis conditions. So that's it. Then coming to the gastritis, pylorospasm, ulcerative colitis. In all these conditions, they can slow the motility and help the patient. Okay, so antispasmodic effect for overactive bladders and urinary incontinence, that is one effect. And when there is cholinergic poisoning, if the drug or any poisoning is there where cholinergic action is more, that is excessive muscarinic action by the muscarinic poisoning, that is mushroom. Okay, M for M, remember, muscarinic, mushroom poisoning, and also organophosphorus poisoning. So organophosphoric is a cholinergic excessive action. In both these conditions, it is a drug of choice. Atropine is the drug of choice. How do we give it in atropine in these conditions? In organophosphorus poisoning, which route? We give it by intravenous route. Okay, every 10 minutes we are giving 2 milligram till the signs of atropinization are there. So anti-secretory action, that is pre-operatively we are giving it. Okay, lower respiratory or upper respiratory tract, decreases the secretion. It helps in prevent the vagal stimulation and potential bradycardia also. So Parkinsonism, what were the drugs? What were the drugs in Parkinsonism? Why you people are sleeping? 3 drugs. Parkinsonism: benzexol, bepiridine, trihexyphenidyl. Okay, these are the 3 drugs which are used. Okay, why we are using? In order to prevent the cholinergic excessive activity, that is tremors, rigidity, all these things are prevented. So it also helpful in decreasing the salivation, spasticity and tremors. So coming to the drug interactions. Okay, so if atropine is used, which drug should not be used along with it, and if it is used, what are the side effects? Okay, so absorption of the other drugs is slowed. That means any drug which is given along with it. For example, levodopa, its metabolism, its movement is decreased, and thereby we need to increase the dose. Okay, so and the other drugs where absorption is increased is digoxin and tetracyclines. Okay, their absorption may be increased by slowing the GI motility. So antacids, what they do, if it is used, they can decrease the absorption of this anticholinergic drugs. So it is more common with the orally given drugs. Okay, so antacids we use it orally. So do you remember some of the anticholinergic which can be used orally? Did we discuss some things? I just now told the drug which is used for GE, gastroenteritis. What was that? To decrease the spasm. Dicyclamine. Okay. So it is common habit that we use the antacid when the patient is in GE. Okay, so the patient will be vomiting repeatedly, he will have gastritis, all these things. So we need to take care of that. The dosage duration is different, or one is used at least half an hour or 1 hour prior to the other drug. Okay. So antihistaminics, tricyclic antidepressants, phenothiazines, pethidine, all have this anticholinergic properties. So when we are using them together, they can be additive side effects. So MAO inhibitors, they inhibit the metabolism of this bepiridine and others. So once the action of this anticholinergic drugs is not done, okay, what can happen? It can go for symptoms of atropinization. Okay, that is blindness, mydriasis, dry as bone. Okay, all these things can appear when we use a MAO inhibitor together. Do you remember some MAO inhibitors? MAO inhibitors are monoamino oxidase inhibitors. Chlorgeline, salicyline, phenylcyclamine, all these drugs are MAO inhibitors. They are primarily used as a antidepressant drugs. So where the drug is contraindicated. Okay, sometimes when there is myasthenia gravis, hyperthyroidism, glaucoma, mydriasis can inhibit this. Whatever the minimal movement is there, it can go for acute glaucoma conditions, tachydysarrhythmias. Okay, all these conditions, there can be problems. And also there is some GI problems, where maybe some gastric tumor also, where the minimal spasms or minimal movement of the GIT is necessary, something like paralytic ileus, some disease conditions where GI motility is already decreased, we cannot use these drugs. So toxicity, these are just the symptoms of the atropinization. Okay, we have studied it, that is mad as hatters, dry as bone, red as beet, yeah, blind as bat, no girls, no active participation. So difficulty in maturation, dilated pupils, photophobia, blurring of vision, excitement, ataxia, delirium, hallucination, hypotension, convulsions, coma at very high doses. Okay. So how do you treat this condition? We can give it by 1 milligram neostigmine subcutaneously, fail to induce muscarinic effects. Okay. So neostigmine, we give neostigmine and see that whether there are any muscarinic effects. And if we fail to see that, that means there is problem with atropine toxicity. So treatment is gastric lavage and tannic acid, that is potassium permanganate. Okay, all